says things like, well, nobody should be on them long term. Why?
Hey, I'm Dr. Julie. I'm a board certified psychiatrist, and I wanted to stop by to provide maybe some additional context or information about why some psychiatrists may be hesitant to prescribe benzodiazepines, that's medications like Klonopin, Xanax, Valium, etc., long term, and particularly for conditions like insomnia. I do want to explain that I spent most of my clinical career, over a decade, in the VA hospital system. So in that population, there's definitely a high prevalence of anxiety disorders, trauma-related disorders, and also substance abuse. And I want to make that point because the type of population that you work with, the type of comorbidities that are seen in the population can definitely influence your prescribing practices. I also want to say that psychiatrists are not sleep specialists per se. That is a fellowship that you can do after your general psychiatry training. But we're not technically sleep specialists, but because insomnia is such a large part of so many mental health conditions, we do often end up treating insomnia, sleep problems very often. So what would be a typical scenario in my clinical practice is that individuals would have presented to their primary care doctor initially. That's in the VA hospital system, a very common model. So they have some services in primary care. So initially the individual would have presented to a primary care. And so oftentimes when I'm getting a referral, it's on a person who has had a benzodiazepine started by someone other than myself. And we know how busy primary care doctors are and how many things they have to address, particularly, again, in my population, in the VA population. It's a population that skews older. Individuals tend to have a lot of very serious medical conditions and take lots of medications. It wouldn't be unusual for me to see a person who was on 25 medications. So oftentimes I would get an individual who was started on a benzodiazepine in primary care. And a lot of times what would happen is that they would be prescribed the benzodiazepine, often for sleep, and then over time, right, what tends to happen is that dose doesn't work anymore, so the dose starts escalating, and then at some point the primary care individual would get uncomfortable with the dose or how things were progressing or the lack of response, and then they would send them over to psychiatry. And why this matters is because not infrequently, I would encounter people who were never really educated on the potential for tolerance and dependence with long-term use of benzodiazepines. And so when I prescribe benzodiazepines, again, Valium, Xanax, Klonopin, etc., I always talk to the individual about the potential for tolerance and dependence. And I don't couch it in addiction. Because there's a negative connotation to that. And really, that's not what it is. What I would say is, hey, we've exhausted these other options. And now we're at this option. And if you take this medication at a certain dose, that dose can vary for different people. If you take this medication daily at a certain dose, then it is likely that you are going to become dependent on it. And I kind of explain, that just means that your body is used to that dose. And if you wanted to stop it, depending on your dose, we may have to taper it off and you could have a withdrawal syndrome. So for me, when I prescribe a person a medication, whether it's a benzodiazepine or not, and there's a potential for tolerance and dependence, I think it's very important that the person be educated on that. Because what will happen sometimes is people will say, well, I never knew that. And some people get really upset with the idea that, okay, now I'm dependent on something. And if I want to change to something else, I have to go through cross tapering or I have to wean off of it. So that's something that's really important for people to know up front. And if you're familiar with benzodiazepines, you know that taking a benzodiazepine with something that can decrease your respiratory drive, like alcohol or opiates, can be a very dangerous combination. And so, again, the population that I would see is skews older. So a lot of people do have chronic pain. Maybe they get to a point where they do need to be on opiates chronically. And so maybe they're coming to me for other options outside the benzodiazepine because it isn't safe for them to take the opiate and the benzodiazepine together. But what I'm saying is, again, I would educate the person, if you are taking this medication, depending on the dose and some other things you might take, like opiates, if that becomes necessary, or if you drink on this medication, particularly with some benzodiazepines, they have a very long half-life. So a lot of people would say, well, hey, if I want to go out tonight and I want to have a drink, I'll be okay. Some people say, hey, I just want to take my benzodiazepine tonight. Well, if you're taking a short-acting benzo, like Ativan or lorazepam or Xanax, which is alprazolam. If you're taking a short-acting benzo, that strategy may work well. But some people are taking a very long-acting benzo that if they take that daily, that would be like Valium or diazepam, Klonopin, clonazepam. Those are very popular long-acting benzodiazepines. If you're taking that and you still don't take one tonight, it doesn't mean that it's in your system. And I have had people who have inadvertently hurt themselves, meaning got to a point where they were obtunded or very sedated, maybe had to come to the hospital because they didn't realize that just because they didn't take a long-acting benzo, that it wasn't gone. It's over time, if you take it, it builds up in your system. It's not going to be metabolized, all of it in one day. So missing one dose isn't going to make it safe for you to drink alcohol with it. The other thing I wanted to mention, particularly as people age who have been on benzodiazepines chronically, there is the risk of the potential cognitive issues. Again, as this video mentioned, there's other medications that can have that potential impact too. But there's also a risk of falls. And I mean, again, I worked in a population that has older people. And once you've seen somebody, you know, who used to could tolerate a certain dose, now they're not tolerating that dose as well. They're having like changes in their mentation. They're falling. If they fall and break a hip, there's so many negative outcomes to that for their overall health and well-being that it is important to be educating people, particularly as you age. Yes, I know you used to could tolerate 2 milligrams a day of clonazepam, but as you age, or maybe because these are the medications were added, you may not. We may need to look at decreasing the dose or changing to something else that's not going to increase your risk for falls. But I've definitely encountered people who are very benzodiazepine averse, you know, who prescribe those medicines, and I feel like they just don't want to be involved in the process of some of like this consent and the monitoring and having difficult conversations with people. Again, I had to have that conversations with a lot of people as they maybe get older, because they, you know, I mean, you want to take something that works, right? If I've been taking it this long and it works for me, then why would I change it? But if they're starting to have negative consequences, sometimes there are challenging conversations about, you know, what to do or what other options we can do, so that we, you know, we want you to sleep, or we don't want you to be anxious, but we don't want you to have another very negative outcome, you know, that worsens your overall health and well-being. But I do not vilify any medication. You know, there are medications that are great for some things, like lithium. You know, that lithium has saved so many people's lives who have bipolar disorder or who suffer from chronic suicidality. But it can have a negative impact on your kidneys. And for people who've taken that and they've had that impact, it wasn't good for them, you know. There are other medications like thalidomide. That's a non-psychiatric medication, but a lot of people may have heard about that. When pregnant women took it, it produced, you know, a really significant birth defect. But thalidomide has been brought forth now and is being used to treat like multiple myeloma, and it's really extending people's lives. And so I guess my whole point is that any drug, any medication, depending on the person, depending on the situation, can be positive and get, you know, good effects, or you can have, you know, a negative effect to it. I'm just not a fan of like vilifying, you know, really any medication. You know, I'm always about, you know, that's one thing I would say in my VA hospital system. I felt very like privileged, is that we had a very good sleep department. We actually had a psychologist who had specialized in working with people who have sleep disorders. So, you know, we had CBTI, cognitive behavioral therapy for insomnia. She would do nightmare rescripting. That's an evidence-based treatment for people who have trauma-related nightmares. In my experience, it's very hard to find people who do those kind of interventions. So we could offer that in addition to the medication to help people when they do have like chronic sleep problems. So anyway, I feel like that, you know, to me, medication is just one tool in the toolbox. I don't believe in vilifying any of them. I do believe it's important, benzos or anything else, to be sure that people have consented and they fully understand the potential, you know, benefits of the medication and the potential side effects of the medication. So I just want to give a perspective that might be helpful in this case.